Hello, hello, hello. There we go. Okay. Welcome, everyone. Thank you for being here. I have to apologize for starting at 12 instead of 11:30. I am actually on call, and I ended up having to do some work. So I do appreciate all of you who got the notice and are here with me. And I hope that we are able to talk about something that you go away with, something you can learn, um, or you can learn a little bit more about what we're talking about today. So I see that a few people are joining, so I'll probably give us a few more minutes to get more people here. Hi, Nanama. Thanks for being here. Hi. All right. We'll go ahead and wait a few more minutes. I know that with me changing the times, some people might take a few extra minutes before they get here. How are you doing, Nanama? Excellent. Good. Thank you. I'm trying to follow in your footsteps. The amazing diabetes work that you've been doing over the years. All right, I'll give it about 2 more minutes and then I'll go ahead and get started. Okay, I think I'll go ahead and get started. I don't want to take too long because, like I said, I'm actually on call, so I could get called in any minute. Um, but I promised to do a live today, and I wanted to keep my word. So, um, for those of you who will be joining who don't know who I am, I'll go ahead and introduce myself again. I am Dr. Banga. I'm a board certified osteopathic obstetrician and gynecologist, so an OBGYN. What that means is I practice both obstetrics, which is the care of women from getting pregnant, through their pregnancies, through the delivery and the postpartum period, and gynecology, which means that I take care of other female-related conditions and needs. So one of the things I'm trying to do is do a series of topics about conditions or topics that come up frequently in the office, and just do general overviews about them. I won't be giving specific medical advice during these sessions, but just giving you information that maybe helps you to learn a little bit more about the various conditions or topics or things that you've heard about and maybe have some questions about. So I surveyed a few of you as to what you wanted me to talk about, and the topic that came up most was fibroids. So I thought today I'd do a little overview about fibroids, and just hopefully this helps to answer some questions about it for you. So I see some more people are joining. Hi, Alina. Thanks for being here. I'm, again, for those of you who don't know where I am in Greensboro, North Carolina, and I am in private practice. And at the end of this, I will show you how you can follow me. All right, so fibroids. Pretty sure most of us have heard about fibroids. Um, I'm not sure if there's a lot of mystery about it, but it is one that I do tend to get a lot of interesting questions about. So, hi Michelle, hi Ramat, thanks for joining. All right, so fibroids are a very, very common tumor that a lot of women will, at some point in their lives, have. Statistically, I think it's about 70% of Caucasian women at one point will have a fibroid, and it's higher in the black population. It's in excess of 80% of black women by age 50 would have had a fibroid. Fibroids come in a lot of different shapes and sizes. They are benign tumors, mostly. There's a less than 1% chance that develop into cancerous tumors, but 99+% of the time they are benign tumors. They develop from the muscle layer of the uterus. The uterus is made out of smooth muscle, and for some reason, some of the muscles decide to go a little haywire and form little solid tumors. So I have a little handy dandy pictorial here to show you what your uterus looks like. And I know you can see the ring from the camera in here, so I hope it doesn't blur it too much for you. But I will try and show you, as I use some of the terminology, I'll try and show you what it actually looks like on the uterus. There's several different kinds of tumors, and they can be multiple different sizes, and they can be in different places. You can have just one, you can have multiple ones. A lot of times, the way you know that you have a condition that could be a fibroid is because you either have a lot of pelvic pressure or you have irregular or heavy bleeding. Those are the symptoms that most people present with. The pressure can be just in the lower pelvic area. Some people will notice that they're urinating more frequently. Some people have a little bit of trouble using the bathroom for bowel movements. Some people will notice that their abdomen starts to get bigger, and it's not necessarily because of a poor diet. And then, of course, with the bleeding, you can either just have very heavy menstrual periods, or you can sometimes bleed in between periods as well. Now, there are several other things that could cause these symptoms as well. So it doesn't mean that anytime you have these two things that it's automatically a fibroid, but it definitely warrants a workup. Hi, Sania. Oh, thanks for joining. Have people joining from all over. Excellent. Thank you, guys. Okay, so a little bit about the things that predispose you to having fibroids. We already talked about how prevalent it is. So over 70% of Caucasian women, over 80% of black women. Mostly it tends to be present in women in their fertile years. So in the years during which your ovaries are making estrogen. Because fibroids do tend to like estrogen, and they tend to grow in environments where there's a lot of estrogen. So on average, somewhere between your 30s to your 40s are about when most women will know that they have fibroids, or start having fibroids that maybe start growing some more. Also, another thing that can predispose you to having fibroids that get bigger are anything that causes you to have extra estrogen. So birth control pills that have estrogen in them can sometimes cause fibroids to grow a little bigger, although they can also be used to treat them. It's interesting. There's family history there, so fibroids do tend to run in families. Diet. So there are things that you can eat that have a lot of either plant estrogen or animal estrogen in them that can sometimes cause fibroids to increase. So I usually will sometimes tell people to stay away from things like soybeans and whatnot, because we know it has some phytoestrogens in there, so plant estrogens. There are some things that can cause fibroids to shrink. I don't know that everybody necessarily wants to do those things, but specifically, smoking is known to shrink fibroids. I'm not proposing that anyone with fibroids go out and start smoking. Um, and another thing that is sometimes a little tricky to talk about, but has to, is we tend to store estrogen in our fat cells. So the heavier we are, the more estrogen we have in our peripheral cells. And so that can sometimes be a contributing factor to fibroids growing. So smaller framed people sometimes tend to not have fibroids that get as big as they could. All right, so we've talked about the people that typically get fibroids, how you typically present with fibroids. So let's say you have fibroids now. What do you do about them? Your decision to manage your fibroids really depends on what your life plan is. If you're at a point where you decided you never want to have children, or you are done with having children, then the plan for you could be a little different from somebody who has never had children and wants to have children. So, again, let me pull out this tutorial here, and I really hope this shows up well on here for you. So here is your uterus, okay? Pretty little thing. All right, so you've got your uterus right here. This is the inner lining of the uterus. This is where babies grow, in here. There's your fallopian tubes. There's your ovary. Although this makes it seem like the fallopian tubes are attached to the ovary, they're not. They kind of just hang there. So when it comes to fibroids, like I said, there's several different kinds of fibroids. And you have your pedunculated fibroids, which means that they kind of hang off the uterus. So they hang off via a stalk. So the fibroid itself is not attached to the uterus, it just hangs off of it. Those ones really don't distort your uterus much. They don't cause a lot of anatomic issues to the uterus. But if they're growing outside of the uterus in the pelvis where you have bowel and your bladder and everything, they can still cause a lot of pressure. So they may not cause a lot of bleeding, but they can cause a lot of pressure depending on how big they are. So there's your pedunculated. Then you have your subserosal. So the capsule layer that covers the uterus is called a serosa. So a subserosal means it's literally under the lining of the uterus. So it's just covering. It's almost like a thin blanket just covering it. So it's under the top layer of the uterus. Obviously, those can be easily accessed from above the uterus, not inside the uterus. And that matters when it comes to how we manage those. You have your fibroids that are in the muscle layer of the uterus. We call those intramural fibroids. Those can be tricky because if they're in the muscle of the uterus, that means that you generally have to cut into the muscle of the uterus to access them if you're trying to take them out. And then your final type will be your submucosal. So mucosal means that in a moist lining. So submucosal are usually on the inside of the uterus. Those are the ones that folks tend to have issues with mostly when it comes to having babies or having miscarriages and things like that. Although all of them could contribute to that. So just once again, you have your pedunculated, you have your subserosal, your intramural, and your submucosal. Okay. So important to note that you could have fibroids that are all of these. So you could have a fibroid that is spanning the entire muscle layer here, which means it has a subserosal component, it has an intramural component, and it has a submucosal component. And those get tricky to manage sometimes. All right, so I said the way you manage the fibroids really depends on what your plans are. Starting from the most drastic, if you're done having children, you don't plan on having children, your bleeding is so severe that you're needing blood transfusions, and your quality of life is being affected. You've got pressure. Every 2 hours you're having to go to the bathroom to pee because you've got these humongous fibroids and you just want to be done with them. One of the most definite ways we can take care of those, and I start from the drastic and I work my way back, will be a hysterectomy. So with a hysterectomy, we will be taking out the uterus, most likely the cervix, and then we can talk about your tubes and ovaries, but that's not the topic for right now. But a hysterectomy is taking out your uterus and your cervix. That's a total hysterectomy. And if you did that, that would take out the fibroids. It will take out the source of your bleeding, the source of your pressure, and you'd be done with them. But not everybody wants to be that drastic. Oh, I see more people joining. Hi, Nanama. Nanama Chumba. Oh, great. And Pinky and Chantrell and Hamdulay. Thank you guys for being here. Okay, I'll get back on topic. I was focused on fibroids. But yes, if we did a hysterectomy, that would take out the entire uterus. And again, a hysterectomy, a total hysterectomy, is taking out your uterus and your cervix. However, if that's not the route you want to go, then we can work our way back a little bit. If you have multiple fibroids, but there's one that's really big and it's the main one that's causing a lot of problems, you can try to focus on just that one, and we can sometimes go in and try to take out just that one fibroid. That procedure is called a myomectomy. So a myomectomy is us going in and taking out the fibroid. Depending on where the fibroid is located, it affects the way we go in and take it out. Sometimes some people want to take out multiple fibroids, so you take out a whole bunch of different fibroids from different areas. Most people who want to do that are people who are still trying to conserve their fertility. They want to still have a chance of having a baby, or they just don't like the idea of not having their uterus in there. There are a lot of people who want to have their uterus still in there. It's a part of them. They want to hang on to it. I'll probably be like that. But if we take out multiple little fibroids from different areas, of course, there could be some long-term repercussions that we would need to talk about. Going back to our pictorial here, as you can imagine, a pedunculated fibroid that's just hanging off a stalk, if we went into, the way we would take that out would be we go in abdominally and we essentially just cut it off from here and we take it out. That way it does not affect the muscle of the uterus. It stops putting pressure on the organs here that it was affecting, and we usually would have to do this procedure either through a cut on your abdomen, so like a C-section cut, or sometimes we can do that through a procedure called a laparoscopy. And laparoscopy means we go in with a camera and we take it out, so we would take it out in pieces. You could also do a robotic removal of it. Laparoscopy has been a little tricky lately for fibroids because there was recently a situation where if we're taking it out, we would have to take it out in pieces if we're taking it out from a tiny little incision. So if you're doing that, there's theoretically a risk that little pieces of the fibroid could still be left in the abdomen. And a lot of times, 99% of the time, that's not going to be a problem. But remember, at the beginning of this, I told you there's a less than 1% chance of time that fibroids can be cancerous. It can be a cancerous lesion. And there was a study, I'm sorry, not a study, but there was a patient, unfortunately, who did have a little piece of fibroid left that did develop into cancer. So because of that, a lot of the equipment that we use to take out the fibroids in pieces were recalled. There are safe ways of doing this where we would take the fibroid out, put it in a little bag, all in your abdomen, and we take it out to the bag so the little pieces are still in a bag. And so there's safe ways to do this, but that's probably going a little more technical than I meant to go into today. But I can certainly do another live on that. But pedunculated, essentially, we're just shaving it off from the side of the uterus and taking that out. And it can be done abdominally, or it can be done either with a laparoscope or with a robot. The next one that might be relatively easy to manage would be probably the subserosal, the one that's just under the covering of the uterus, the blanket layer just laying over it. So subserosal, usually if you're taking that out, you don't get too deep into the muscle layer of the uterus. And that is important, especially for those who still want to have children. If we cut too deep into the muscle layer of the uterus, sometimes we can cut into the inner layer, and that can sometimes cause some scarring. So it's important to know that. But with a subserosal, you can come in same way, either by making a C-section incision and going in, or using a laparoscope. Little tiny incisions on the belly. You go in and you shave that out. You carve it out. I'll talk about the intramural next because that's similar. Again, to remind you, the intramural is the one that's in the muscle layer of the uterus. You do typically have to cut into the muscle layer a little bit to access it. So we can still do this abdominally, we can still do this laparoscopically, we can still do this with the robot. The trick is to know whether or not, for the surgeon, to know whether or not you access the lining of the uterus, because that'll be important for if you want to have more children. Like I said before, if you access the lining of the uterus, that can cause some scarring. And it can also weaken the muscle of the uterus. So depending on the size of that fibroid, if we take this out, sometimes we will recommend that if you do get pregnant, you not have a vaginal delivery. Because when you have a vaginal delivery, you're having contractions. The uterus muscle is just contracting all through labor. Some people have labors that are 2 days long. Some people have labors that are an hour long. But they still have intense muscle contractility. And if there's a weak area in that muscle, it could technically rupture. It could technically open up. And that means that the placenta that is providing nutrients and blood flow and everything to the baby could be disrupted. So the baby could be compromised, basically. And that could result in a stat C-section. You want to avoid a stat C-section if you can. So a lot of times if you've had a myomectomy, again, that is the removal of a fibroid, and it's gone past the muscle layer into the inner lining of the uterus, sometimes your OBGYN might recommend that if you were to get pregnant, that you do not. I see there's some questions on here. I'll try to go back and look at the questions. This is my first time, guys, so I'll go back and look at the questions and try to address them at the end of this. I'll get through all of this because, again, for those who joined later, I'm on call, so I could technically get called in at any moment. So I'll get through the lecture and then I'll address the questions so that everybody gets the information, okay? But thank you. Yeah, keep them coming. I'm more than happy to answer them. So yes, we may recommend a C-section just to preserve the muscle of the uterus for the safety of the baby. And if we do recommend that, sometimes we will recommend you do it before your due date. So your due date is 40 weeks out. I don't know why we always say 9 months. It's 10 months. It's 40 weeks out. We may recommend it when you're full term, which is at 37 weeks, depending on how big the fibroid was, where it was located. The fibroid that tends to be addressed through a different route would be the one on the inside of the uterus. So that was our submucosal. So that's the one that's pushing on the inner lining of the uterus. So as you can tell from the pictorial, it would be easier probably to access it from inside the uterus instead of accessing from the outside. So with that, typically, if we're going to try to address that fibroid or take that fibroid out, we might opt to do that through a different route. So we try to go vaginally, and we use an instrument called a hysteroscope. We go in vaginally, and we shave that down. Sometimes on the main way, okay, back up. The main way that we can sometimes locate the fibroids is by using an ultrasound. We can definitely feel them and palpate them in the office when we do your pelvic exams. We can tell that your uterus is maybe a little bigger than it typically should be for your age, weight, and all of that. And sometimes it's pretty definitive. You can tell, you're like, oh, there's a fibroid right there. Other times, you're just suspicious. So if we need some further imaging to help us locate the fibroids, usually our first modality will be an ultrasound. And an ultrasound is usually pretty good at locating them. Sometimes, however, you need more imaging. So very rarely you may need to do like an MRI or something like that to locate the fibroids, but for the most part, you can, I see more questions, yeah, I'll get to them. For the most part, you can see the fibroids on ultrasound. If we have a question about whether a fibroid is also pushing through into the inner lining of the uterus, we will do a different kind of ultrasound. Even though in this picture it looks like the uterus is a nice, here, let me pull it back up here. Even though it looks like you have a nice cavity in here, that's not really what your uterus looks like when we look at it on ultrasound. On ultrasound, there's not a big open space there, usually flattened. So sometimes we can't tell what's really on the inside lining. So we'll do an ultrasound called a saline-infused ultrasound, where we put a little thin straw-like device through your cervix into the uterus. We push some saline, so salt water, into your uterus, and that opens it up a bit. And then we can see the inner lining, and you can see there's a fibroid pushing in on it. So if we do a regular ultrasound and we can't tell for sure, we may recommend to you that you do a saline-infused ultrasound. And when it comes to those submucosal fibroids, when we access those to the vagina, to the cervix, and to the uterus, we do have different devices that we can use to just shave them down so that the fibroid is now flush with the lining of the uterus. So it's not pushing in, and it's not caving in, it's not distorting the cavity. So that typically helps a lot with fertility too. Okay, so let me make sure that I answer some of these questions and come back. Let's see. And hello everybody again, and thank you for being here. Hi Pinky. Thanks, cuz. Alright. Is there any risk to not doing anything about fibroids, just letting them be? Absolutely. Great question. You don't always have to do something about a fibroid. As I said before, fibroids come in many shapes and sizes. I get a lot of people coming to see me because they were getting a scan done or a surgery done for one or the other reason, and incidentally, they said, oh, you have a fibroid. These people have never had pain, never had abnormal bleeding, never had any issues at all. Also, sometimes at the beginning of pregnancies, when we're doing ultrasounds, we're like, oh, guess what? You have a little fibroid here. And they never would have known it otherwise. They have no symptoms from it. You don't have to do anything about a fibroid if it's not bothering you. The only times you need to address them are if they are causing a lot of pelvic pressure that's disruptive to you, or causing heavy bleeding, especially bleeding that is causing you to maybe need a transfusion or make you anemic, or just disruptive to your life. I have people that sometimes bleeding through the clothes in meetings and things like that because they can't control it. And remember, we're working our way back. We started with surgical, and we'll work all our way back to the medical options that we can use as well. So not everything is surgery. I like to start from the drastic and work my way back, because then the conservative options seem more palatable to some people sometimes. So yes, you do not always have to do something about a fibroid, and that's mostly if it's not disruptive to you. Now, if we have a fibroid that grows really rapidly in a very short period of time, even if it's not causing any symptoms of discomfort or bleeding to you, we may recommend that we go ahead and take that out simply because of that very, very small risk that it could be something cancerous. But most fibroids are pretty slow growing, and a lot of us are walking around with them and don't know that we have them. All right, let's see. What was the other question? Is it true that women of African descent have a higher risk of uterine fibroids? Any thoughts on why that is? Yes. So at the beginning of this, I did say that statistically we know that about 70% of Caucasian women will have or have had a fibroid. But it's in excess of 80% of black women. If we look at the raw numbers, it's about 2/3 of the African American population will have fibroids compared to other races. The why, we have that list of different things that could contribute to it that I went through at the beginning. I'll go through that again. Age is universal, so we can't use that. Family history, so the genetic component to it. Do we have diets that have more plant estrogens in them? We know that, for example, there are certain foods that have more plant estrogens in them. There's that well-referenced Nigerian culture that tends to have a lot of twins. I don't know, there's something with the diet there with the yams. We do know that diets that do have a lot of plant estrogens in them, so soybeans, things like that, can be used therapeutically sometimes to help. I'm not a naturopath, so I tend to really leave that aspect more to the naturopaths, but I do have some excellent naturopath colleagues that I can get on here to give us some more information about that if you guys do want me to, so that we can explore that a little further. But are certain populations using more medications that have estrogen components to them, so birth control and things like that? That's a possibility. And then the other thing that I referenced was the fact that we do store estrogens in some of our peripheral fat cells. So if we're heavier, just our body dynamics might contribute to that as well. But there's definitely statistically a higher rate of fibroids in the black population. Let's see. Do they affect hormones? Compromise sex drive, compromise experience of sex? They certainly can. If you have a big bulky mass sitting in your pelvis, it might make sex uncomfortable. It could make you bleed after sex, which makes you not want to have sex. It's a negative feedback loop. So yes, it can distort your uterus to where certain positions are more uncomfortable. So in those circumstances, if that's the only problem and the person does not want to go as far as surgery with that, like I said, there are medication options that I'll get to. But other things you can do is try different positions to see if maybe there's some positions that are not as uncomfortable. Sex drive, if it's that feedback loop, if every time you have sex it's painful and you bleed and it's uncomfortable, yeah, you might not be as inclined to do that. Okay. All right, so working our way back, I'll make it through all the therapy. So we talked about the most drastic, hysterectomy. We talked about taking out just the fibroids through the different routes, either through a C-section scar, through laparoscope, through robotic, through a hysteroscope. If you don't want to go that drastic, and we also talked about not doing anything at all. So actually we covered both extremes. I'll start working my way back this way. If the issue you are having is just some heavier bleeding, but it's not horribly disruptive, sometimes you can start off with um, anti-inflammatory medications like ibuprofen, Aleve, either while you're having your period or just before. And sometimes that's enough to minimize the bleeding to where it's tolerable to you. You can also do birth control pills because yes, I told you that birth control pills can sometimes make the fibroids grow. Usually, I would recommend probably more of a progesterone only birth control. So there are pills that you can use for that. Um, there's the Depo-Provera injection you can do, but the one that a lot of people find most helpful does tend to be IUDs, intrauterine devices, which are birth control devices that and I use the term birth control, but in this term, in this realm, we're not necessarily just using it for birth control, we're using it for cycle control. So we put these little devices inside the uterus. We do it right there in the office. And what they do is they thin out the lining of the uterus, and they don't provide estrogen. So you're not getting any extra estrogen, but that can sometimes cause, because the lining of your uterus is thinned out, it can cause a lot of people to have either significantly reduced cycles or no cycles, which is great for a lot of people, and it avoids surgery. So there's that option there. There are other options that, sorry, I saw a question here and it distracted me a little bit. But, all right, so yes, there's birth control medications that we use for cycle control for these instances. There are other medications we can use that would actually decrease how much estrogen your ovaries are making, which, again, remember, fibroids grow when there's a lot of estrogen. So if you can decrease how much estrogen the ovaries are making, then that can either stop the growth of the fibroids or shrink them. So there are two different classes. There are aromatase inhibitors. There are GnRH agonists. I'll just give you the general idea about these. But yes, there are medicines that you can use that will decrease how much estrogen the ovaries are making, and thereby help to shrink or decrease or stop the growth of the fibroids. Now, these medications typically have some side effects to them, because any condition that will cause your estrogens to go down a little bit is leading you sort of towards menopause, which is the other topic that a lot of people wanted to know about. But that's leading you towards menopause, and some of the symptoms that go along with that could be, hot flashes, night sweats, insomnia. So they're not, they do have some side effects that may not be as well tolerated by some people, but other people would love to do that because the bleeding or the pressure is so severe that it's disruptive to them. The other benefit to some of these medications is it can affect how we do your surgery. So if I told you that I could put you on a medicine for 3 months that would shrink your fibroid, or potentially shrink your fibroid enough to where I didn't have to make a large C-section incision, and I could rather do your surgery through a laparoscope or a robot, where I make tiny little incisions on your belly instead of a large C-section incision, a lot of people like that option better. So one of the GnRH agonist medicines that we'll sometimes use is called Lupron, and we'll put people on it for at least 3 to 6 months, depending on how much shrinkage we want and how much they can tolerate it. And that can decrease the size of the fibroids, shrink them, so that we can do minimally invasive surgery rather than abdominal surgery. The thing about those is you don't want to be on them too long term, because the downside of downregulating your ovaries, decreasing your estrogen component is, one, you could decrease your bone density as well. But more importantly, once you go off those medicines, usually the fibroids grow back. So typically, if I'm putting someone on that, we're also having a conversation about, okay, once we're done with the 3 months or the 6 months, then we're doing surgery. So it's not a long-term treatment option if we go with those routes. So those are some of the standard ways that we manage fibroids. However, there are two options that are not always available in different places. These options that I went through: surgery, myomectomy, birth control pills, the GRNH agonist, aromatase inhibitors, not so much, but it's an option. Most OBGYNs have access to doing them. There are two options that can be used to manage fibroids that are not typically managed by OBGYNs. So one of those would be a ultrasound guided, or it also is sometimes called an MRI guided focused ultrasound. And this is where they put you through an MRI machine and they use targeted ultrasound rays to target the fibroid, to use these ultrasonographic waves to attack the fibroid, basically. And it kills the fibroids, they heat up the rice, and it kills them, and they dissolve on themselves. The other one is called a, what's it called? It's called a, thread them through the, let's see, I got some OBGYNs on here. What is it called? It's called a, I just went blank. Okay, I'll tell you the procedure, and as I talk, it'll come to me. But the radiologist does this, and they thread these little beads of seeds through your uterine artery embolization. So they put these through your uterine artery, so they go through your blood vessel, and they put these little blood clotting beads or seeds into the uterine artery, the blood vessel that feeds the uterus, and it basically blocks off the blood supply to the fibroid, because fibroids grow their own blood supply. They're like little parasites. I just grew up in there. I didn't need to put that pictorial in your mind, but they are. But they, so you put these little blood clotting seeds through the uterine artery, and it blocks off the blood supply, and essentially they die. So these procedures are usually done through a radiology suite of some sort, because you need an MRI, or you need an embolization catheter to be put through there to feed into it. So these we OBGYNs don't typically do, but we can refer you to get those done. I would not recommend that you consider these options if you're still considering having children, because at some point there are waves that are destroying a portion of the uterus, or blood supply to a portion of the uterus, and so you're not sure how viable the uterus still would be for a viable pregnancy afterwards. So this is for folks who don't plan on having more children, but they don't want to go as far as doing a myomectomy or a hysterectomy. The downsides to these procedures could be, as the fibroid is dying on itself, it's necrosing, it's dissolving, it can cause pain, and sometimes the pain can be severe to where you have nausea, vomiting. So the first week or so after this, we'll usually counsel folks that you could feel kind of cracky. But not everybody does. And sometimes when the blood supply is affected, the fibroid can prolapse out. Ignore that. Yeah, it can basically do it. Okay, I hope that wasn't too graphic. Let's see. Let me go back to these questions here. And let's see, I think we answered that one. Perfect, Thomas. Is there a medication that can dissolve the fibroid? Well, I don't know if there's a medication that can specifically dissolve the fibroid, but with the targeted ultrasound or with the embolization, those would be ways that you could dissolve the fibroid. And so I hope that was helpful. So let's see, we talked about folks that typically get fibroids, the risk stratification for them. We talked about symptoms of presentation. We talked about what to do if you want to have more children, not have more children, how we treat them, and whether you even need to treat them. And I think I did a full evaluation of that. You guys have any other questions or anything that I didn't touch on? And again, I apologize. I haven't slept all night. Been at the hospital all night, so I'm a little bit over here and there. I need a little bit of a nap, so bear with me. And this is my second time doing this, so my technology skills will improve with time, I promise. I think that's it. Oh, helpful. Oh, thank you, Anastasia. Okay, I'm glad you found that helpful. Let's see if there was anything else I wanted to talk about with the fibroids. I think that's the main thing. Thank you, Ramat. If you guys have any follow-up questions for it, please send them to me. I won't mind doing a more organized lecture about it, but I really hope that you found that to be a bit helpful in demystifying a bit. They are very common. They're not a death sentence when you have them. We have things we can do to treat and manage them. Yes, you can still have children if you plan on it. The key is if you do start having symptoms that are bothersome, pressure, bleeding, anything like that, go see your OBGYN. Let's see what's going on. They're not always going to be fibroids. It could be something else causing it. But if it's a fibroid, don't worry, we can handle it. Okay? Even if you have to end up having a baby by a C-section. Okay? All right. Do fibroids shrink in menopause? Yes, they do. So again, in menopause, because we tend to not make as much estrogen, fibroids do tend to shrink then because you don't have as much estrogen going. So that is another thing that I do tend to talk to people about. The closer you are to menopause and the severity of your symptoms, we can determine if this is something we can maybe just manage if you're already in the perimenopause phase or your early menopause and your symptoms are not that severe. We could just say, with time, this could actually get better. So we can watch that for a little bit. And I'm glad you brought up menopause because that was, again, the other topic that a lot of people wanted me to talk about. So maybe the next live that I do, I will do it on menopause, okay? And I will try to make these a little more organized, so I do them weekly. What I thought I wanted to do was alternate an obstetric topic with a gynecology topic. So, and maybe in between there, I will throw in some talking to your children about their bodies and their anatomy topics. So, actually what I'll do is next live, I will do an obstetric topic. And then the next GYN topic I will do after that will be menopause. Okay? All right. So thank you again. I really, really appreciate everybody that joined in and all your questions and the feedback. Really appreciate it. Don't forget, I am on all social media now under Dr. Banga OBGYN. So Dr. Dr. Banga BANGA OBGYN. So I'm on Facebook, I'm on Twitter, Instagram, TikTok, Pinterest, and I'm on LinkedIn. So, all right, have a wonderful day, everyone. Take care, and thank you again.